Hello folks, today we will discuss this paper which was published just recently in the NEJM on which among the three commonly used anti-epileptic drugs works best in status epilepticus. In patients with status epilepticus, there is fairly robust evidence to support benzodiazepine use as first-line treatment. However, seizures become refractory in some patients, and it remains largely unclear as to what may be the most optimal treatment among these patients. So this paper asks the question, is it levetiracetam or fosphenytoin or valproate that may be the most effective in this situation? The study design was a 3-armed, blinded, randomized trial across 57 emergency departments in the US. The study population included children as well, so essentially patients older than 2 years who presented with status epilepticus. Stratification was performed according to age category between 2 to 17, 18 to 65, and more than 65 years. And all these patients received a standard dose of benzodiazepine, but even after the use of benzodiazepine, they had generalized seizures for more than 5 minutes or continued to have seizures after 5 minutes of the last dose of benzodiazepine. So that was the study population involved. How did they randomize their patients? Conventionally, you would do a 1-to-1-to-1 pattern of randomization in such a study. So that's what they did for the first 300 patients. But after the first 300 patients, they used the Bayesian method to allocate more patients to the study group that seemed to be more effective at that stage. That is, after the enrollment of the first 300 patients in a 1-to-1-to-1 ratio, they allocated more patients to the arm that looked like more effective at that stage. Why is this done? This is to reduce the sample size and give you an appropriate power to the study with a smaller sample size. They plan to do analysis after 400, 500, 600, and 700 patients were enrolled. And they try to figure out the predictive probability for the most effective or the least effective treatment. A predictive probability of more than 0.975 with any drug, and the study would be stopped for success at that point. And if the predictive probability was less than 0.05, the study would be stopped for futility. So this is all based on, as I mentioned, Bayesian analysis, not the commonly used frequentist method. So they assessed 400 patients for eligibility. After exclusion of 16 patients because of re-enrollment, they had 384 unique patients who were randomized to receive levetiracetam in 145 patients, fosphenytoin in 118 patients, and valproate in 121 patients. The dose of levetiracetam was 60 milligrams per kilogram to a maximum dose of 4.5 grams. This, you may note, is a slightly higher dose compared to the standard dose of 1 to 2 grams bolus that many of us use in our daily practice. Fosphenytoin was used in a dose of 20 milligrams per kilogram of phenytoin equivalent to a maximum of 1.5 grams of phenytoin equivalent, while valproate was used in a dose of 40 milligrams per kilogram to a maximum of 3 grams. So that's how the study arms were split. Each of these drugs was administered over a period of 10 minutes, and of course it was blinded. What was the primary outcome of the study? Cessation of seizures with improved consciousness at 60 minutes after the commencement of the study drug was the primary endpoint. And what did they find with these 3 medications? They looked at the predictive probability of each of these drugs being the most effective or the least effective, as I mentioned, according to Bayesian analysis. Roughly about 46% of all patients achieved seizure control at 60 minutes. You might argue that this is not a very big number, just about 46% or so. With levetiracetam, 47% of patients achieved control of seizures and improved consciousness at 60 minutes. This number was 45% with fosphenytoin and 46% with valproate. The figures that you see in brackets is actually the credible interval, which is similar to the confidence interval that you use with the frequentist method. So that's actually 95% credible interval. So if you look at the predictive probability for the most effective or the least effective drugs among these three, there was really no difference at all. And they all seem to be equally effective or equally ineffective for that matter. And that's the figure that shows the patients with treatment success in each of these arms, fosphenytoin, levetiracetam, and valproate, and they all seem to overlap with their credible intervals, which suggests that they were equally efficacious in the control of seizures in patients with status epilepticus. They looked at some secondary outcomes as well, which included the time to cessation of seizures, defined as the time interval between the commencement of infusion to the cessation of clinically apparent seizures, the number of patients who required ICU admission, as well as the number of patients as well as the length of stay in ICU and hospital. In fact, the duration of stay in ICU, the median duration of stay in ICU was just 1 day in all the three groups, and the length of stay in hospital was a median of 3 days in all three groups. So fairly short ICU stay and a short hospital stay as well. So the authors came to the conclusion that all these three drugs, levetiracetam, fosphenytoin, as well as valproate, were equally effective in the control of seizures in patients with status epilepticus, and their adverse effect profile was also similar. So that was the conclusion of the authors. Now let's look at, were there any limitations to this study, and how would you extrapolate the findings of this study to your practice? One of the limitations was that electroencephalographic monitoring was not routinely used, and the assessment of seizures was purely based on the evidence of motor seizures. Non-convulsive seizures were not evaluated at all. So that is one of the limitations. The second question is, if indeed the control of seizures is of prime importance, would you rather use an intravenous anesthetic early and intubate these patients? Use, say, propofol or ketamine early, intubate them early, rather than delay things with the administration of drugs which take a longer duration to act and perhaps result in uncontrolled seizures for a longer period of time. Obviously, you have to balance the benefits of seizure control with the possibility of harm with intubation, ventilation, and so on. In this study, as I mentioned, intubation was considered as failure of treatment, or the use of medications, including intravenous anesthetics, was considered to be a failure of treatment. So would it be more appropriate to intervene earlier if seizure control is indeed of crucial importance, and intubate them early? So that question remains unanswered. It's obviously not a limitation of the study per se, but it's perhaps the practice that is followed by many of us in day-to-day practice. And as I mentioned previously, if you look at adverse effects, there was very few adverse effects noted, which made meaningful analysis very difficult. And you couldn't come to any definitive conclusions as to which of these drugs may have more adverse effects. One of the lessons that needs to be drawn from this study and also from the guidelines that already existed even before the study is the dose of levetiracetam. The bolus dose of levetiracetam, as I mentioned, with many of us in our daily practice is about 1 to 2 grams. So that obviously may not be a good enough dose. You may need to use a much higher dose of 60 milligrams per kilogram with a maximum dose limit of 4.5 grams. So that's one of the take-home points from this study. Levetiracetam is very much dependent on an appropriate dose, and many of us may be underdosing in our day-to-day practice. So that needs to be perhaps one of the lessons that you need to draw from this study. So that's all, folks. This study clearly shows that there is nothing much to choose between these 3 drugs, and perhaps by default, being the least harmful of all, levetiracetam would perhaps be the choice in this situation. And of course, one should consider using intravenous anesthetics early and intubating them early if seizures seem to be prolonged or taking a longer time to control. Thank you. They also looked at safety outcomes. The primary safety outcome was a composite of life-threatening hypotension and life-threatening arrhythmia. And this composite safety outcome was also similar between groups. In fact, the incidence of life-threatening complications was very, very small. Hypotension occurred in just 1 patient, the levetiracetam arm, 4 patients with fosphenytoin and 2 with valproate. Life-threatening arrhythmia occurred in just 1 patient. So these numbers were actually very, very small.